Well, good afternoon, everyone. Welcome to Lunch and Learn with the Health Education Committee, Connecting for Breast Cancer Awareness. My name is Chantel Archer, and I am the chair of the Health Education Committee, which is a committee of the Connecticut Public Health Association. On behalf of the committee, we would like to thank everyone for participating in this Lunch and Learn on breast cancer awareness, which is the final one of the year. Many of you may already know that breast cancer is the most common cancer among women of all races and ethnicities, and that disparities exist when it comes to screening, treatment, and mortality. For these reasons and more, the committee felt it was very important to host a lunch and learn on this health topic. These lunch and learns are meant to inform, educate, and empower people about health issues, as well as increase the competency, skills, and performance of the public health workforce as they relate to the 10 essential public health services. Before we continue, I would like to remind everyone to please keep yourselves muted during the presentation. We would also appreciate if you would enter your first and last names in the chat. This is especially important for individuals who are seeking CHES credits. And during the Q&A segment, please put any questions or comments in the chat box. Finally, this Lunch and Learn is being recorded and the recording will be available on our webpage. Now I'm going to turn things over to Jamie Luckhart, who is one of the core members of the Health Education Committee, and she is going to be introducing today's speakers. Jamie?
Hi, good afternoon, everyone. Thank you so much for attending. I'd like to introduce our speakers for today. We have Dr. Beth Jones. Beth Jones is the Associate Director for Community Engagement in the Center of Engagement and Health Equity for the Yale Comprehensive Cancer Center. She is a cancer epidemiologist who focuses on health disparities. With more than 20 years of research and teaching experience on the faculty of the Yale School of Public Health, she has led multi-year investigations, systematically evaluating factors that contribute to relatively poor cancer outcomes and a real-world efficacy of cancer screening in African American and Hispanic Latinx populations. Today, she leads the CAPE initiative, which stands for Cancer Action, Prevention, and Engagement at Yale, a community-facing bilingual multicultural team that focuses on community-engaged outreach, education, research, using a multidisciplinary strategy in which the social determinants of health are always on the forefront. Thank you, Beth, for coming today. We really appreciate having you. And next, I would like to introduce Monique Stefanou. Monique is a community health educator and the lead health navigator for the Yale Cancer Disparities Firewall project. She received her master's in public health from Southern, wonderful school, in 2012, and her current work focuses on improving access to preventative care along with the cancer continuum. She specifically works on engaging healthy individuals in appropriate cancer screenings and prevention behavior. Her health navigation work aims to specifically provide services for African American, Hispanic, Latinx, low socioeconomic status individuals and communities here in New Haven, Connecticut. So welcome to the both of you, and thank you so much for joining the Health Education Committee.
Thank you.
Thank you. Shall I begin? All right, so yes. I'm Beth as Jamie, and thank you, Jamie, and also just for the invitation to both of you for including us in this wonderful series you have. So Monique and I will be kind of partnering as we do this, and Monique, would you mind advancing to the next slide?
Oh, 1 second.
So we're going to be talking about the intersection, breast cancer and the intersection with social determinants of health. So the key themes we're hoping that you'll walk away from is certainly having a better sense of breast cancer disparities, sort of where they occur and how we look at them, both from a research perspective, but also in terms of knowing how to intervene. So we're going to talk about breast cancer disparities and that sort of intersection with social determinants of health. And then finally, so I'll be covering the first two topics, and what I would like to be doing, you'll notice it's not a clear distinction between the two. I will be weaving information about social determinants of health into breast cancer disparities as we go along. And then the most important part here is how do we, knowing what we know about disparities and knowing what we have observed for many, many years about how those play out in terms of breast cancer outcomes, how do we disrupt this? How do we change the course? And Monique will be presenting that really important aspect of what we're doing. So next slide, please. So just briefly, I know you've been talking about heart disease and climate change and all kinds of things. So just for those of you who are less familiar with cancer, I mean, in a nutshell, all cancers are about normal cells, something occurring which transitions them to kind of abnormal growth patterns. And eventually some of them take over as solid tumors, and depending on where these grow, and the size of them, eventually they often sort of disrupt the normal function of whatever organ they're occurring in. And of course, the reason they're of most concern is around breast cancer is those cells can leave the breast tissue and they can go to lymph nodes where they can spread in other places of the body, and then sort of set up shop in other organs and actually cause outcomes that are undesirable. So just in this pictograph of the breast, just to remind you, most breast cancers occur in the milk ducts of the breast, not all of them, but most of them do. All right, so next slide, please. So just really briefly, what are the risk factors? Well, I've kind of organized this in terms of sort of the reproductive factors, which we, and I say we, the epidemiology about breast cancer has been well established and was in place for now, decades. But there's some reproductive factors such as, having an early period, not having children at all, or having the first pregnancy after the age of 30, having a late menopause, and then also taking hormone replacement therapy. So sort of the unifying theme there is that because this is a hormonally driven cancer by estrogen as well as androgens and other hormones, the longer that a woman lives in that period of her life where she has estrogen. So if you think about from when you get your period until menopause, the longer that is, and with fewer disruptions, and actually pregnancies disrupt the normal cycles. So that's why that's actually protective. The longer that exists, the greater the chances of breast cancer in general. Those are particularly the case for hormone-dependent cancers. There's also genetics, of course. We know that having a strong family history predisposes women to breast cancer, and there's specific mutations that are really well established, BRCA1 and BRCA2, that are associated with that. And then finally, in breast cancer, there's lifestyle factors. So alcohol is a known risk factor, as is being overweight. And with many cancers that we now talk about disparities, I don't think this was always appreciated, but what goes along with being overweight and obesity, in fact, is that there's sort of it sets up sort of an inflammation in your body, and that's bad for hearts. It's bad for and actually plays a role in a lot of cancers in terms of growth factors and things. So let's move on. So let me just, actually, if you could go back one slide, Monique. What I did want to say about that is when we think about the hormonal risk factors, in fact, women of color, particularly Black women and Hispanic women, I'm going to, when I talk about disparities here in Connecticut, those are the groups that have been studied the most. Those are the ones we know the most about, just because they're in larger numbers. But actually, we know much more probably about breast cancer in Black women than even in Hispanic Latinas. But the reason this is kind of intriguing is, in fact, when it comes to reproductive factors, Black women are actually at lower risk than white women. And that might explain why we see that the incidence of breast cancer is lower in Black women. And you might also be looking at this and thinking about, well, okay, reproductive factors, I really can't do much about those, and genetics, probably not. But the factors that we concentrate on, and you'll hear more about from Monique, is actually about the lifestyle, because those are the ones we can intervene on. Okay, now I'm ready to go forward. Okay, so most common cancers, breast is the most common cancer that occurs in women in the United States. It's corollary in men is prostate, another reproductive cancer, lungs secondly, and then colorectal cancer third. But it's important to note that lung cancer is the cancer that's responsible for more cancer deaths than in both men and women. And next, please. So there, as we noted, it is common, and there are a lot of deaths due to breast cancer nationwide. Next, please. So what about social determinants of health? I know this is, we're all hearing a lot about this. And this is the way the Healthy People 2030 frames it. They have this wheel. And so some of it is about, and I would say, you know, this is a moving field right now. People call different things social determinants of health. But importantly, you know, things like education, economics, financial aspects, healthcare access, and the neighborhood in which you live. For some years, we've been hearing that place matters. It fits into here. And then also the social and sort of community context in which one lives. And what's really interesting here, and it hasn't always been the case, is what you'll see is on most of these, there's the word quality added. And that's important because very often we can say that people have access, but if they don't have high quality access, and if there are race differences around those quality issues, that contributes to the disparities that we see at the end, at the you know, outcome end. All right, next, please. So when it comes to, just let me make this local, you can see here, these are in the statewide data are shown on the left, and New Haven data are on the right. Now, what you can see is, first of all, the race distribution is very different statewide than it is in the city of New Haven. So the city of New Haven is actually, the majority population are non-whites, Hispanic, Latinos, or African Americans. That's not true at the state level, of course. But more importantly, if you look at the very bottom here where it says 10% of the population in the state of Connecticut lives below the federal poverty level, but in the city of New Haven, that's 26%. And unfortunately, New Haven is not alone here. This is true of all of the urban areas in Connecticut. And because of the hyper residential segregation that exists in this state, we know that in most of our cities, there's an overlap between people of color and low socioeconomic status. And that certainly is driving a lot of the disparities that we see in cancer and in other diseases. And in COVID, of course. Next, please. So just to break this down around breast cancer a little bit, next, that was just to clue me into transition. So we look at incidence rates and mortality rates. These are US data, and what you can see in green are the incidence of the new cancer cases. And what's interesting is both incidence and mortality use the same denominator. So generally, the rule is if you see that you'd see the same pattern. But in breast cancers, it's different. As we can see, the incidence rates are highest in whites. Sorry, what you will see is my lights go off now and again, and I'm going to wave around like a mad woman to make them come back on. But the incidence rates are highest in whites, but in pink with the mortality data, you can see in the second column, set of columns, is that the mortality rates are highest in African-American women. And other groups, you know, this certainly plays out differently across the country, but we don't have the same representation in Connecticut. But we also see that Hispanics' mortality rates are higher than they are for some other groups. Next, please. So there is one exception to this rule about whites, the incidence of cancer being higher in whites, and it has to do with younger age groups. So up until about age 44, the incidence rates are shown in pink here for African Americans, and they are slightly higher in Black women than they are in white women at younger ages. And that is a very important fact. Even though the numbers, it's still a rare disease. It doesn't occur frequently in young women, but it does, it's not non-existent, particularly in younger Black women. And that has to do with sort of, it's really important in terms of how the national guidelines for cancer screening are set, whether or not that has been taken into consideration. And in general, the upshot of this is no, the studies that have determined our screening guidelines are basically large studies that were done many years ago, mostly white populations. Next, please. So when we think about breast cancer, we can, we know that, you know, if you were diagnosed, one of the first questions be, well, you know, how advanced is it? That's certainly an important prognostic indicator. And what you can see here on the right is the data for whites, and about 63% of cancers in white women are diagnosed while they're still confined to the breast. They haven't spread to the axillary lymph nodes or to other parts of the body. So much more treatable, and the outcomes are certainly far better. What we can see for Black women, that's about 54%. And for Hispanic Latinas, it's somewhere in between the two. And I've been working on breast cancer for many, many years now. So when I first started, probably close to 30 years ago, that spread, it's now what, that's like I can't do the math that fast. What is it, 11%? When I first started looking at data like this, it was 12%. So we've made huge progress in terms of treatments, in terms of more women being screened, but we continued to carry this gap between racial ethnic groups with us across decades. So next, please. So how do we go from thinking about a concept like race to observing race differences in mortality and survival? And we know that there are also race differences that I've just shown you in stage of diagnosis. How do we break this down? Where do social determinants of health come into this story, and what are the factors that we need to look at? So next, please. So this is a complicated slide, but it is just to make the point that as I did, and it's not a beautiful slide because of my limitations in terms of creating graphs like this, but if we want to think about what we should look at to understand this process, there's a whole lot of variables we have to look at. And what you'll notice up front, or in turquoise, is that right up front, we know that socio-demographic factors, socioeconomic factors, and sociocultural factors, access to care, influence the race differences that we see in stage of diagnosis and in some of the variables there, as well as other variables and factors that even if women have the same stage of cancer at the time of diagnosis, we still have worse outcomes for Black women and for Hispanic Latinas. And why is that? Well, there's a whole bunch of other factors, like the kind of tumor you're diagnosed with, the treatment that you were given or adhere to or that works for you, psychosocial factors and biomedical factors such as obesity and things like that. So I'm going to talk a little bit about, so what I did not mention is the racism is certainly an important issue too, that sort of, if you think about this, is just kind of these umbrella sorts of effects that kind of affect any variable sort of down later in the pipeline. And then also things like neighborhood, place, and residential segregation. I think, Monique, if you hit your thing again, there's some others. So when we started studying other groups, certainly with a large immigrant population or Hispanic Latina population, factors such as acculturation, which is a variable about how long people have been in this country, how acculturated are they, that plays a role, and it's also one of those social determinants, I would add. There are other factors such as language barriers, cultural competency of the healthcare providers, and health literacy as well. So all of those factors, the idea, these are sort of broadly grouped for our purposes in studying as social determinants, but they do impact the more biological drivers of cancer outcomes. So next, please. Okay, so I'm just gonna see, I can't read the chats and I'm not going to right now. Yeah, thank you. So looking at this again, just to break it down, we are going to talk about, actually, I think the next slide, with now just trying to look at how race predicts what we see as race differences in stage of diagnosis. So on the next slide, yeah. So this is work that we did here in the state of Connecticut. It was across the entire state looking at differences between Black women and white women. We have done similar work on Hispanic Latinas, which was being written up now. But I guess where I'm going with this is when we think about race differences, it's very nuanced. So what we are starting to see is parity in terms of actually getting screened. It looks like a lot, if we just look at the national survey data, we see that the screening rates are much higher, or almost equivalent now between Blacks and whites. But how could that still not be sort of answering the question about why we are seeing race differences in the stage of diagnosis? Well, we asked a question with a study here at Yale, and as I say, it was statewide. Was it possible that white women were more likely to be adhering to the guidelines, getting screening on a regular basis than were Black women? Whether, and just putting aside, not attributing fault to anybody, but was it just not occurring as often? And as we know, screenings, one screening exam might pick up a cancer, but that's not the point of it. The point is to do them regularly at appropriate intervals so that we catch cancers when they are still small and treatable. So here we saw that there was a race difference in terms of, adhering to the guidelines as they were intended. It wasn't quite significant. And the data here for African Americans are shown in pink and then whites are in green. However, we did ask another question. Well, is that because, when women come in and get a mammogram, do we know, are we, the system, good at communicating those results? And what we found was that Black women were much more likely to say, I never got those results. And there was already a state law in place at that time, a national law. So we knew these letters were going out. And even though we didn't have the data to really deconstruct this completely, we were left with the idea that it may have had to do with the fact that the way that we were communicating results, it shows up in a white envelope, wasn't effective. It looked like a bill perhaps, or women at the time of their mammogram did not understand the process. They did not know to expect their results arriving in the mail. So this predates my chart, of course, but this is a really important fact. How would we expect women to know when to come back, especially if it's abnormal, if we haven't communicated the results properly? And of course, then the last thing was we looked at women who had a screening mammogram for which the results were abnormal. They didn't necessarily have cancer, but there was certainly something that needed to be followed up on. And what we found was that Black women were more than 3.5 times as likely as white women to not come back for that appropriate follow-up. So here we've done this great work in getting women out to get screened, but some little small piece of this system falls apart. And this is where the social determinants of health really kind of continue to, eat away at the healthcare system, at the effectiveness of it, because we haven't accounted for the fact that maybe somebody can't get a ride, they can't get time off from work to come for that follow-up exam, or if it's a person for whom English is not their first language, or they manage to get out in the world speaking English, but they don't actually read it. These are all issues which could contribute to these factors. All right, so next, please. And I will kind of speed this up because I need to. So just to say that there are other factors, and that's perhaps one example where we can see how social determinants of health play out in just one aspect of this really complicated disease process in terms of screening to help us to understand why there's still race differences in stage at diagnosis, even though it looks from our national data that women are being screened appropriately. So as you know, if you just one more time, Monique. Mm-hmm. Yeah. So one of the places that we've also looked, and there's a lot of work around, is that there are tumor characteristic differences. And if we look at the next slide, we know this as well. And this is earlier work in which we showed here in Connecticut, but it's well known that the tumors that we were seeing in African-American women initially were, and I say African-American women initially, actually have features, biologic features that put them at a little bit higher risk. They're hormonally more likely to be hormone negative, HER2 negative as well. And then in the work that we did, we showed that there were P53 differences. P53 mutations were much more common in Black women. So we now know that this sort of is what we see in terms of the genetic profiling that is done on tumors. The important thing here was, without studying large groups of Black women, nobody knew that breast cancer, I'm not saying we did, there was certainly all this work going on across the nation, but by studying large groups of Black women, we started to see this pattern of breast cancers that actually impact a lot of white women as well. But we weren't seeing it to the same extent in large groups of white women as we were in large groups of Black women. So we learned a lot by studying, by making it a concerted effort to make sure that we were studying and we were doing outreach to engage people of color in our research. So if we can just move on, and I think it's time for me to turn over. I would just want to make the point that these social determinants interact with factors all along this one disease pathway, but it is true for most of the cancers we work with and a lot of other diseases as well. So if we could go to the next one. Next. Thanks. So again, these are the sort of key themes that I'm going to turn over now to sort of how do we disrupt this process? We now know, we understand a lot more about how we end up with certain outcomes, but how do we disrupt it? And I think that was the last of mine. Yes. Thank you, Monique.
Thank you, Beth.
Thanks for moving slides.
You're very welcome. So as was mentioned earlier, my name is Monique Stefanou, and I'm going to talk about this piece of, how do we disrupt these outcomes? So we thought we would share about who we are a little bit more. So Beth and I are part of the CAPE, Cancer Action Prevention and Engagement at Yale. So this is our team. I think almost everyone is here on our team, and we are comprised of faculty at the Yale School of Public Health, health navigators like myself, community health educators. Part of my time, I'm a community health educator, and the other part, I'm a health navigator. We have research assistants, masters in public health students, CROI scholars, or the younger age, sometimes coming out of high school and going into undergraduate college. So we have a very diverse team, not just in what you see on the screen, but also what people are able to bring to the table. So it's been a pleasure to be a part of this group. So our team, CAPE, that is our job to disrupt these outcomes. And where we're doing that, this is called the Cancer Control Continuum, as many of you may already know about. But where we are approaching the cancer control continuum is at the prevention and detection stage. So that's where we're working to disrupt the outcome. There's different ways where researchers alike all across the world are working on these different parts of this cancer control continuum, but we're working at the prevention and detection stage. And since we're talking about breast cancer, then we're going to make it relevant to breast cancer today. So what do we mean by disruption of outcomes? What are we trying to work on? So there's 3 different spots that we can work on. One, an incidence. So we can definitely attempt to prevent new cases. Concerning mortality, we can work to make sure that if somebody has breast cancer, that is detected earlier. And why is that important? Because if it's detected earlier, there are a lot more treatment options that are available to that individual compared to if it's detected later. And then regarding structural racism, we are attempting and working hard to address the social determinant of health barriers, and I may refer to that as SDOH barriers. As we know, even with history of things like redlining, there are things that are systemic in our society that racism has racism has led to these SDOH barriers. So we are disrupting outcomes even in this area as well. So strategies for cancer prevention, since we're talking about breast cancer today, in the pink box are the different things that can be done regarding prevention as far as people not getting breast cancer. So Beth talked about how there are certain things we just cannot control, but there are other things that we are able to work on. So what is that? So maintaining a reasonable weight, increasing physical activity, eating the appropriate amount of fruits and vegetables, also increasing our fiber intake and reducing fats that are not good, and then also limiting alcohol consumption. And all of this is important, not just from the point of a community health education talk, but this is also the way in which we interact with community members. And what do I mean by that? So we have something called the Health Navigation Program. This is a part of the Yale Cancer Disparities Firewall project, which is funded by the Bristol Myers Squibb Foundation. And in this program, we're aiming to do some critical things, especially as it relates to social determinants of health. So what happens is that community members come in. So these are not people who are already patients. It's really important that we make that distinction. We know a lot about patient navigation, but these are people who are not patients at the hospital. We meet them in the community or receive them from the community through a variety of means. And they come into our program and they establish health goals. They want to work on healthy eating, or they want to work on weight management, or they want to work on making sure they get their cancer screening test on time. And so they establish those goals with us. And then we do a social determinant of health screening with them to see what are other social needs that they might have that we can support them with, all with the aims of disrupting the barriers, right? So they establish their health goals, they get screened for SDOH needs, and then we provide them what we call a geocoded resource list. And these resource lists, it's sent electronically to them, or it can be mailed to them, or in some cases, we also text it to them. And it provides both social and health resources in one sheet or several sheets, depending on how long the list is. That's within 5 miles of where they live. And that's really significant because we're talking about disrupting barriers. So in times past, people would say, okay, I have this great program, come to me. But the program may be 10 miles away and somebody doesn't have transportation to attend that program. So our health navigation program is providing both social resources as well as health resources to make sure that people are, one, staying on the preventative path, but also are getting their screenings on time when we help them to overcome those barriers as well. And then additionally, we have regular telephone support. So the program is completely over the telephone. And we are in contact with our members at least once a month to make sure that, one, they got the resource list, they're able to access the resource list. So we're really intervening to make sure we're not just handing them lists and say, okay, we gave you the resources, but we're following through to make sure they're actually able to reach those resources without difficulty or challenge. So that kind of comprises, in a nutshell, our health navigation program. So they say that a picture says 1,000 words. So we thought that we would give you a story regarding one of our members. This person, obviously we have taken away name and identifying information, but I believe that the story will really give you a better flavor, if I could say it that way, of what the program is all about and how we're able to impact lives in the greater New Haven community. So I'll just go ahead and play that.
Hello, my name is Eduardo, and I'm a health navigator for the Yale Cancer Disparities Firewall project, and I would like to share a story about one of our health navigation program participants with you. Yolanda migrated from Puerto Rico to Connecticut in 2000 without family and friends. She also didn't have a strong English language skills. Yolanda misses her beautiful island, Puerto Rico, and she has a difficult time navigating the healthcare system. Yolanda decided not to attend a doctor's office and never had a mammogram or any cancer screening as she was afraid of the test and didn't want to know the results. She was afraid that she wouldn't understand her results and fear of not knowing what to do with the outcomes. One day, Yolanda attended an American Cancer Society breast cancer walk-in in New Haven and met a health navigator from the Yale Health Navigation Program. Later that day, she attended a Spanish language health education session where she learned more about cancer screenings. Yolanda learned a lot about U.S. healthcare and was no longer afraid to go to the doctor. Yolanda set clear goals for medical appointments with the navigation team, went to her doctor's appointments and completed her mammogram and other cancer screenings. Yolanda continued to work with her health navigator and is presently up to date with all her cancer screening examinations. She is currently interested in nutrition counseling resources to help her in continue choosing healthy foods. The navigation team will continue to remind her about her next mammogram and other medical appointments as needed. And Yolanda is happy that she found help in her own language.
So that's kind of a short story of how one of our members came into the program, the fears that she started off with, and the resources that she needed in order to complete one chapter of her life with us, even in getting her mammogram. And it talks about, this is a nutshell, but it also just reminds us how there's various different levels. Sometimes it's the education. People are not aware about what a mammogram is. People have heard horrible stories about getting a mammogram, the language barrier, the transportation to the appointment. So there are various different things, even as Beth alluded to earlier, that comprise this whole picture of somebody staying on top of their screening, but also maintaining a healthy lifestyle. You see, even in this story, it was once she got over that barrier with getting her mammogram, now she's more interested in healthy eating. So I think another really unique thing about our program is that we're making sure that we're addressing the needs that the members present with first. We're not rushing to them saying, I'm here, you must get your cancer screening, your mammogram is important. We're saying, okay, what's your present need right now? Some of our members, their present need is that they need food, and they need somebody to say, where can I get food from a food pantry? So I think, just like Beth talked about on other slides, there are many different things that are going on in the lives of individuals, and we're there to make sure that they have what they need. And it's not just about the cancer screening piece, but that holistically, they have the care and the services that they need. Okay, so when we talk about social determinants of health services, this is a graph. We've recently conducted an evaluation of our first cohort that most members stayed at least 1 year and some members stayed 2. And it shows you what types of services that they needed. Finding food, that was 66.7%. So 66.7% of individuals who completed the evaluation, they actually needed to find food. Others, it was paying utilities. For some people, it was personal safety. And then you can see housing and finding transportation. And so this kind of gives you a little snapshot of the other things that are going on in people's lives that might serve as a barrier to them staying healthy, as well as getting their cancer screening. Something also important to know, and I'll try to be quick as well, is that when our members came into the program, it was 40% needing food assistance and 35% with housing concerns. But with the onset of COVID-19, that's increased, as you can see here in the graph. And the other thing that we try to do as CAPE is to recognize what's going on in the community. Yes, we have our main agenda, what we're trying to work on, cancer screening prevention and making sure people have access to preventative lifestyle resources, and also making sure they get their cancer screening on time. But the other piece of this is that we're aware of what is going on in the community. We have worked very hard to embed ourselves in the community. Myself and my colleague Jose de Jesus have gone into the community for various events, even prior to COVID. And then we also routinely attend what they say are community management team meetings. So we responded even to that, to what was happening in the community when COVID happened, and made sure that the community members had masks. So we've learned that it's not enough just to have our own initiative and to just push that through. We are trying very hard to embed ourselves into the community. And then if we don't have the resource, then we find others, like with the mask situation, to make sure that people had masks and hand sanitizer and knew how to properly wear their mask when everything started. So our team talks about here, so cancer screening, finding cancer early. So that's why we specifically work with lung cancer, breast, colon, colorectal cancer, prostate, and cervical, because there are screening tests that are evidence-based. And so that's why we focus on those cancers. And just to kind of give you a little snapshot. So the other thing that we do is we provide education. So we have our health navigation program, but we routinely have community health education events where we would explain to someone, okay, mammography, what is it? The individual in the story, she was afraid of it. And a lot of times people are afraid because they don't have the knowledge to know what's really happening. So we let them know that it is an x-ray of the breast. We give them a picture, show them an example. These are things that we probably already know on this presentation, but it's just to kind of give you a snapshot of what a lecture might look like as well. And we also remind people that when cancer is detected early, it is often easier to treat. And that's a lot of times where fear comes in the community, because people feel like, oh, cancer, that means that's it, it's over. When in reality, that's not true. And then we all, of course, make sure that people are aware of who needs a mammogram. So our program, based on evidence, suggests that mammography screening would happen no younger than age 40 and no later than age 50. And that you continue with mammography screening until at least age 74, and you get a mammogram at least once every 2 years, or as often as once a year. The important part of, we also remind members of the community, is that it's very important to have conversations with your healthcare provider, because even though these are the evidence-based recommendations that we are recommending, it is very important that the provider knows their health history and whether or not there's something in their history that would cause them not to follow this guideline verbatim. And that's why we talk about people with increased risk should definitely have a conversation with their provider as to when and to start and stop screening, as well as their level of risk, as well as the different benefits that particular tests might provide them. So we're going to wrap up, and I think I'm going to actually let Beth wrap up this slide. There's a very important point that needs to be made here.
Oh, thanks, Monique. I guess, after, I'm old, so I've been working on this for a long time. And every breast cancer talk on disparities, I always end with this because I'm always floored by it, which is we've made huge progress around breast cancer and treatment, mammography. Everybody does, it's a very treatable disease for most people. But the current 5-year survival rate from breast cancer in African-American women is 82%. And that's almost, and it's in white women, it's about 91, I believe. That's almost the same as it was for white women 25 years ago. And I will end on that to say, despite all the amazing progress that's been made, we still, and we make progress, but we carry this difference between racial ethnic groups with us decade to decade. And it's not, this is, I think, where the role is for social determinants of health and understanding the very nuanced ways that they still continue to contribute in a negative way to these outcomes. And I think the work that Monique was describing is, we're a small program, but it's one attempt to sort of do something very practical to intervene and address these other barriers so that we have better outcomes in general. So I will leave it there. And thanks, Monique. What a great presentation on the work that we're trying to do to disrupt the things that have gone wrong in the system so far. So thanks.
Yes, thanks too, Beth. So I think
Thank
I'm going to
you.
stop sharing so we can answer questions, if that makes sense.
Thank you so much, Beth and Monique. You've shared a lot of great information today, and I'm sure many of you have questions for our presenters. So I'm actually going to turn it over to Dina Michinello, who is one of the committee's core members, and she will be facilitating the Q&A segment. Dina?
Thank you. And thank you, Monique and Beth, so much for your presentation. I did work with this in my undergrad, and it's been many years since I even thought about it. So it was awesome to hear, like, wow, a lot has changed since then. So it was great to hear. There was only one question that I could see so far in the chat box. It's from Raymond, and he asks, could public health departments assist in reducing inadequate follow-up as it has in other diseases? I don't know if anybody would like to tackle that first, but that was from Raymond, so thank you.
Well, I can jump in, and thank you for the question, Raymond. I mean, I think, it is definitely a team effort. So, and we certainly do, and I see Jose de Jesus is on the thing and he can wave. He and Monique, as Monique said, part of what we do in terms of laying the foundation for even something very specific like our navigation program is to work with our community management teams and ensure that we are also in conversation routinely through different mechanisms with the health departments. I think in the specifics about how do we get women to return, yes, I think any kind of public health messaging is important in that aspect. But it's some really small tweaks to the healthcare system I think have also made a difference. Something as simple as when a woman gets a mammogram, she is now routinely told when she'll get a result, how she will receive it, where to look for it. And you know what, if for some reason you don't get it, be sure to call us. And very often in getting that mammogram, people now will confirm that person's address, their phone number. Believe it or not, when these problems were emerging, that information wasn't done routinely. So I think it's just sort of being consistent about how we, take care of these little small issues in the healthcare system is really critical. And anybody else, I know a lot of you have experience I don't have, and you're welcome to jump in, Monique and Jose and anybody else. Well, I will just jump out. I know I see Natasha's, oh, sorry, Dina, I'm supposed to wait for you to do the question.
Go ahead. If you see something, there's a couple in there, and if you read it and you have an answer right away, go for it.
So I saw Natasha asking about, and this is a good way to link to what we just were talking about with health departments. Natasha's question had to do with whether we're just doing this in New Haven or we're doing it in a broader way. So right now, this program has been located in New Haven, and honestly, it was we started off kind of going gangbusters, and then COVID hit, and just it was hard to recruit people, and but we still have continued with the navigation of those people. But this is definitely a model that we would love to see sort of, you know, develop a model for how to continue it in other parts of the state. We have cancer centers in many parts of the states of Connecticut, and we would love to, like, and maybe this is a good option for working with the health department and others. You know, it's easier for us because we have contacts here in New Haven, but I think absolutely we would look for other partners in other parts of the state where this program would be beneficial. Jose, do you have anything to add to that? I know you deal with a lot of our other cancer partners in other parts of the state. And
yeah, welcome everyone. And I'm sorry I was late. I had another meeting, and so that's why I came on late. Monique and Beth, awesome presentation. The only thing that I would add is the navigation, other areas like Bridgeport Hospital, Greenwich Hospital, New London Hospital, Westerly Hospital. They're looking at what we're doing and they want to replicate that as far as the navigation. I think in some other parts of the health system, it's kind of a little bit jig-jaggy. You know, you might get one piece of the puzzle here as opposed to another piece of the puzzle here, where with our navigation program, we try to be holistic and try to cover all of those programs. And I think that's what's attractive to the other sites. As far as community health education, yeah, we do stuff all over the state. The catchment area for Yale Cancer Center is the whole state of Connecticut. So when we do events and presentations for community health education, we're all over the state. And now we're into, hopefully coming soon into Rhode Island. So it's exciting to share that message and try to have that cohesiveness, because as you know, we know where those pockets of disparities are. We know zip codes where those pockets of cancer disparities are, and that's where we want to really concentrate that messaging and get folks to get that first screening, cancer screening. So.
And I would just add the navigation program that Monique was describing. It was actually conceived as almost as sort of a pilot project. We have just learned a tremendous amount, and I think now we are at a juncture where we can think about how to, you know, move that forward and make it more scalable.
Yeah, thank you. So that checked off one of the comments from in the chat box, so thank you. The next one that I see is from Phyllis. She writes in and says, earlier in the presentation, there was a graph that depicted a higher rate of breast cancer in younger African-American women. What are some ways to screen breast cancer in younger women besides the traditional ways, I guess?
So this is an interesting point, and actually on NPR about a week ago, you know, somebody who's really active in breast cancer in the state suggested we should be screening younger women. I've been part of, you know, an NCI panel where we looked at this. So my personal opinion, I think that is part of the science of it, is that we should not start screening before age 40, even though we know that it can occur. It occurs earlier in white women and all women, it can. The issue around screening is if we screen everybody at too young of an age, you know, yes, there's cost issues. And I think when we're all cynical, we think, oh, that's the reason. It's actually that we'll have so many false positives and so many women having biopsies, which are going to be negative. And the fear I've always had is that when that happens at a young age, somebody says, oh, that just happens to me. I don't need to undergo screening when I'm older because they've gone through this process and it's been negative. So it's a complicated issue. The science actually doesn't show that we should start mammography screening before age 40. That's where we are now. I think for younger women, I think the biggest take-home message, particularly women of color, is if you have a symptom, a lump, some discharge from nipple, or a change in the way the skin looks on the breast, do not ignore it, no matter how old you are. And what there are lots of stories of doctors sometimes saying, oh, you're too young for breast cancer. Don't worry about that. That's normal. Most of it is normal. But if you're concerned, you know, just persevere. Have that conversation, go to somebody else. That's, I think, where we can make a difference. I know it's not we'd love a nice, easy screening test. And what we also advocate is awareness of your breast. Now, nobody right now still advocates for, routine, you can get clinical breast exams, but not necessarily self-breast examination, the way it was promoted as being a way to cut down on breast cancer mortality. The reason is it didn't show that studies over women followed for many years didn't show that it actually decreased mortality. So again, we don't want to offer something which kind of is like false hope for someone, or they think, oh, I'm doing breast self-examination, therefore I don't need a screening mammogram when it's my time to get a screening mammogram. But certainly being aware of changes in one's breast is critical for everybody. So that's, and Monique, do you have anything that you would like to add to that, or?
No, I think what you said, Beth, is what I agree with. And I think Jose and I, the other thing we've noticed even in our presentations is that awareness of your body is important, because we have heard stories where people were just at their home or in their shower and they found something. So we advocate that people talk to their providers always about their health history so that you know what's going on in the family, but also talking to your provider is not an excuse not to just pay attention at all, because things can happen. So I think what Beth said is I'm in agreement with that self-awareness is still vital. It is still important. And that's something that even at younger ages, women can be mindful of. Just be mindful of what your body looks like. I mean, we've gone to a presentation before and Jose and I were there, and we show these lemons, and it's different ways in which breast cancer can present. And somebody just by looking at the lemon on the screen says, you know what, Monique, I think I have a symptom. And then they went to go get checked. So it's not just to get your mammogram, and once you get your mammogram, forget about everything. No, it's get your mammogram and then still be mindful of what is going on with your body, even in the interim. Yeah.
And certainly the other thing to add is if you have a family history, and the strongest family history is in your what we call primary. So it's, you're either a daughter, your mom, your sisters, grandmother, but on both sides of the family, it's not just your mom's side, it's your dad's side of the family. If you have a strong family history, start talking to your doctor about that. Just share the information.
And Beth, so if you do have a family history of breast cancer in the family, what is the advice for young women on whether or not they should get a mammogram prior to age 40?
I think if your doctor, if you are at high risk, which, there are, just so you know, there's a genetics clinic here at Yale that you can get a referral to for people who do this every day of the week, go through your particular family history and decide what your risk is. And then they will start screening earlier. Sometimes they might do an MRI or something, but they also will do screening earlier. Particularly if somebody has a strong family history, and particularly if you've if BRCA 1 or 2 is in your family. So again, I'd say the key is talk to your doctor, and if you have a really strong family or a family history, get a referral to a genetics clinic where that can be evaluated.
Thank you, Beth.
You're welcome.
So I think in our time slotted time for questions and answers, we probably have one more time for one more question. It's around transportation, and if there are certain things established already to help people transport to their appointments. I don't know. I feel like Monique would have that answer.
Yeah, so that transportation is one of the things that we help people with. And when we say transportation, we're specifically talking about transportation to medical appointments, because that oftentimes can be a better barrier for somebody maybe going to their colonoscopy or going to get their mammography. So we use a system called NOWPA, which many of you may be aware of, where we're able to type in the person's address and zip code and find, what transportation would be suitable for them based on the criteria that they fill out in their profile. So that, like, VO is an example, M7, there's an example, the Mary Wade home has transportation depending on your age. So a lot of the transportation that we've actually helped people with pertains to medical appointments. And I would also say that because of the system we have, oftentimes there are situations where people can walk to a social service because we're able to put them put their zip code in and say, okay, well, I don't have transportation. If I can't find a transportation, if it's a social service, not a medical appointment, then I can find something that's like 0.25 miles away or 1 mile. So we try to work hard to make sure that it's not just the medical transportation, but also for giving somebody a social service, maybe it's a food pantry, that they are able to get to it. So we just try to troubleshoot with that, and also use our resources. A lot of times I'll call Jose, and if he may know somebody who I don't know, so we just try to call around and do the best we can to connect people so that they can get the transportation they need.
And if I can just, I know we're short on time, but I did see one last question from Ms. Samuels, and I just want to, it's so important. I just think it's really important. Her question, I'm not looking at it right now, was like, well, what do you do if you're treated in a way that's not respectful, basically, in your interaction with a healthcare provider? And I think we can all agree that there's as sad of a year as it's been, but the awareness around inequity, social injustice is, the message has gotten out there. And this is a year when no institution is going to put up with that kind of, disrespectful behavior. Sometimes it may be out of ignorance, or maybe there's a cultural divide, whatever it is. I think patients should feel empowered to be treated respectfully. And if you don't feel like it can be easily resolved with that particular clinician, it's just not, it's hard to say that. It's hard to defend yourself. There's communication relations offices in all of the hospitals. And I think this is there's been a turning point here. And it's in the best interest of all of our facilities and people's hearts are, for the most part, in it. We don't want people to feel unwelcome in our healthcare organizations. And I'm not a doctor, but I believe in the goodness of all people, that there is a genuine attempt to address these really egregious problems. It's an important one. Anybody else? I'm sure.
I know we're running to time, but the other thing with that is every facility where somebody is getting a breast exam, there should be a number either inside the actual clinic room that tells you who you can call if in any way, shape, or form you feel like the exam that took place was completely inappropriate. So that's one avenue. And two, at least, I think Jose can correct me if I'm wrong, I think Yale New Haven Health has also started to institute chaperones. So there has to be a witness for sensitive exams. So I think those are two avenues, but they're definitely, if not in the room itself, but when you go to the actual clinic or wherever it is, there should always be a number that you have access to call right away. If something happened, you can leave anonymous information on that line.
So I know we are at the hour, and I was looking at Chi's question, and I think it would be great if we could respond to that last question and then call it a day, because I think that's a great question that we should find out more about. So
thank you, Chantal. I was wondering, so I got skipped over, but yeah.
Because I'm probably the one who was using it. I can tell you in Connecticut, and as you know, terminology. Oh, I just got rid of Zoom. I hope I didn't get rid of all of you.
No, you're still there.
Still here.
I can't see you anymore. I use the term because sometimes I'm unsure which term to use. It's out of my own, ignorance. I think though in the studies that we did here in Connecticut was all based on self-identification. So as with the US Census, they ask, you have a choice. Do you consider yourself Black or African-American or other? And then people can fill in. So in these studies, they were women who just identified more with Black women or African-Americans. Unfortunately, in the state of Connecticut, we don't have huge populations of, say, Black women, from a certain country or Somali or something so we can't really kind of do those sort of studies to break that down, but it's based on self-identification, which I think is the most important part. Good question.
thank you, Chief, for that question. Thank you, everyone, for all of your great questions. Thank you, Beth and Monique, for a really wonderful presentation. I know we all learned, you provided a lot of great information on breast cancer in the intersection with the social determinants of health. I know how important it is to stay up to date on the latest information and the research that's out there, especially in terms of the social determinants of health. So thank you so much. And I'd like to thank all of the attendees for attending this final Lunch and Learn of the year. We hope to see you next year as we continue this Lunch and Learn series. I put 2 evaluation links in the chat. So for those of you who are not seeking CHES credits, there's one link for you. And for those of you who are seeking CHES credits, there is a separate link for you. So I would appreciate if you would all complete the evaluation and give us your feedback so we can plan for next year's Lunch and Learns, what you liked, what we can improve upon. So I would greatly appreciate that. And just thank you again and have a great weekend, everyone.
Thank you so much for inviting us. I enjoyed it.
Thank you.
Thank you.
All right. So I'm just going to give everyone a few minutes to copy the link if they need to. And
thank you.
Thank you, Beth. Thank you, Monique.
Thank you.
Thanks, everyone.
Great. Yeah.
All right.